closer. You're videoing, eh?
Yeah.
3, 2, 1.
Hi, we're just going to go through the arterial blood gas interpretation skill. Firstly, we're just going to go through a couple of indications of arterial blood gas indications. So, obviously we need identification and monitoring of any sort of acid-base disturbances in any sort of critically unwell patients, or anyone that's going to lead sort of prolonged care within the emergency department or ICU. The indication is measured for the partial pressures of oxygen and carbon dioxide within the blood. We need it for the assessment and response of therapeutic interventions such as insulin in diabetic patients or any other sort of medication in patients that are going to have a prolonged stay. Detection and quantification of the levels of abnormal hemoglobin, such as if you've got carboxyl hemoglobins or if you've got methyl-hemoglobins, can be sort of an indication to have a look at some arterial blood gases. We also use it as a procurement of blood sample in acute emergency setting when venous sampling is not available. Typically, venous sampling would be quicker and much more easier than arterial blood gas interpretation as well as sampling, but we're going through arterial blood gas today. So the procedures and methods of interpretation of blood gases is we've got the table in front of us. These are just your general numbers in terms of your adequate and normal ranges of a arterial blood gas. So we've got to go through our PaO2, which is our partial pressure of O2 within the blood. We've also got pH, VaCO2, bicarbonate, and base excess. So for ABG interpretation, there's a 5-step process. It pretty well goes as this. So number one is how is your patient? You don't actually want to be treating specifically just the numbers, but you want to obviously provide, we'll have the numbers to provide a valuable clue as to why your patient is presenting that way and interpretation of the results. You want to try to predict what the results are going to be before you get there. We don't want to use it as our primary responses. We're treating numbers, not patient sort of symptoms or how they look. Number two is assess oxygenation. Is the patient hypoxic? Have they got too much? So the normal pressure should be over 75 millimeters of mercury on air. What we want to do is it's a rough side bit of calculation of 5 times the kilopascals and all that sort of stuff. Bit confusing. Number 3 is determine the pH or the hydrogen ion concentration within the blood. So is the patient acidemic or are they alkalemic? Here we've got our acidemic as less than 7.35, so they're acidotic, and 7.45 they're alkalotic. That's a rough estimate. Anything below 7 or below sort of 6.8, 6.9, they say is incompatible with life. Recent literature has shown that that's actually not quite correct, with people with emphysema and COPD actually having levels below that and still being alive. Number 4 is determine the respiratory component. So your PaCO2 needs to be above or sort of anywhere between 35 to 45. Anything above 45 is you've got respiratory acidosis. Anything below 35 is respiratory alkalosis. So it's actually the flip side of pH. Number 5 that we want to go through is determining the metabolic component with your bicarbonate. So if bicarbonate is less than 22, we've actually got a metabolic acidosis or a renal compensation for a respiratory alkalosis. So it's normally on the flip side of what happens with your PaCO2 is your bicarbonate levels. And again, on the flip side, if you've got a bicarbonate over 26 and you've got metabolic alkalosis almost secondary to respiratory acidosis. So these are our normal values, is what we want to aim for. We've obviously got a base excess of plus or minus 2 millimoles per litre. To understand it sort of simply, there's a big list, and I can put it up for you exactly. Hang on, we'll just scroll down. We've actually got to read it simply in correlation. We've actually got metabolic acidosis, also respiratory acidosis is a low pH and a high CO2. Respiratory alkalosis, high pH, low CO2, so the converse. Metabolic and acidosis and alkalosis obviously converse again, and compensatory mechanisms in terms of respiratory acidosis with a compensatory metabolic alkalosis and stuff like that. Obviously you've got all the values there. So that's sort of a poor man's or a quick man's guide to how to actually correlate the differences in terms of acidosis or alkalosis within the patient. for arterial blood gas interpretations. We've got some considerations or contraindications for arterial blood gas collection or interpretations. So one of the contraindications for arterial blood gas pretty well across the board globally is an abnormal modified Allen's test, which is basically a test where if you can get the patient to make a sort of a closed fist, or if you can close the hand and put some pressure, basically get the blood out of the hand, you then, as the arterial blood gas person taking the blood, you then occlude both your radial and your ulnar arteries with your fingers, and then what you do is you then open the hand up and release the ulnar artery. So what you're doing is you're testing that you've got the blood going from the ulnar artery back to the hand, and if you reperfuse it within sort of 5 to 15 seconds, you've got good perfusion and good sort of feeding blood through the ulnar artery, which means that you can go for your radial artery for arterial blood gas. If you get an abnormal modified Allen's test and you don't get perfusion properly through your ulnar artery, then you shouldn't go for the radial artery because that's your primary source for that sort of hands perfusion. So that's the contraindications. Any sort of local infection, sort of congenital or acquired malformations, burns, aneurysms, if you've got any sort of AVMs, if you've got a renal dialysis patient, fistulas, or any sort of vascular grafts. Also, if you've got severe peripheral vascular disease, you don't want to be sort of touching any sort of peripheral vasculature for that patient, especially in the elderly, and any sort of active Raynaud's syndrome. Obviously, you're going to get cool, underperfused peripheries, so we don't want to touch it in too much of that. And that is sort of your basic interpretation of arterial blood gases.